बस स्टडी ऑफ पहले स्टार्ट होने से पहले फिर मैं आपके साथ एक ले लेता हूँ।
ठीक, चल बाय, अभी मिलते हैं, मिलते हैं।
नहीं ये आपके जो है आपके इंस्टाग्राम से लगाऊंगा। ठीक है,
ठीक है,
और ये ऊपर से कवर अप कर लेगा।
ठीक है, जैसा है, लेकिन फोटो वोटो जैसा तुम्हें लगे वो कर लेना। बेसिकली है ना, ये थोड़ा सा ना, इन लोगों ने ना प्रोग्रेसिव लेंस नहीं बनाया। इन्होंने एक पास का बना दिया, एक दूर का बना दिया। अभी मैंने क्या एक लगाया, दूसरे में साथ ही नहीं करा, इसमें थोड़ा क्लियर है। अरे दिन है, कोई नहीं है क्या इधर? अरे नहीं, आवाज नहीं आ रही ना। अरे किसी को बुला के लाना यार, ये यहाँ पे उसको अवनीश वगैरह किसी को फोन करना। हेलो।
हाँ डॉक्टर ललित,
हाँ क्या?
गुड आफ्टरनून। डॉक्टर दिनेश है।
हाँ दिनेश, ठीक है। एक बार
हाँ,
मैं चीजें सेट कर।
वी आर रेडी फॉर योर इंस्ट्रक्शंस।
ओके 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 ओके। एक बार अपन चेक कर लेते हैं, फिर अपन लाइव जाएंगे, है ना? एक
हाँ
बार गिव मी कमांड, गिव मी कमांड, गिव मी कमांड। ओके ओके, एक बार वो देख लेता। पोर्ट ज्यादा अंदर नहीं है ना, इधर का एक बार लेफ्ट का पोर्ट देख लेता हूँ, राइट का कोर्ट।
Recording stopped.
नहीं नहीं, अभी तो
ये
देयर इज अ क्लैश जस्ट।
ये ज्यादा अंदर है क्या? ये ज्यादा अंदर है, इसको बाहर निकालो थोड़ा सा, कैमरा को बाहर निकालो, कैमरा पोर्ट को बाहर निकालो, कैमरा पोर्ट को बाहर निकालो। पहले
ओके वी आर डूइंग।
हाँ, पहले उसको करो, फिर कैमरा पोर्ट को बाहर निकालेगा।
ठीक है सर।
और निकालो ना, देख कितना अंदर है, बहुत अंदर है।
इज टॉकिंग अबाउट कैमरा पोर्ट।
कैमरा पोर्ट
कर रहे हैं सर, कर रहे हैं।
कोई
बताइए
एक, हाँ अब
एक बार।
अब थोड़ा सा अंदर डाल दो, थोड़ा सा अंदर डाल दो,
यस
थोड़ा
दैट्स
सा,
इट।
हाँ ठीक है, ओके ठीक है। अभी अभी जो राइट पोर्ट है ना, कैमरा को थोड़ा और अंदर डालो, कैमरा पोर्ट को थोड़ा और अंदर डाल दो, और अंदर, थोड़ा सा अंदर डाल दो। ठीक है, बस ठीक है, ओके।
पहले ही सही था।
हाँ, और ये राइट वाला दिखाना, कितना पास में, कैसे?
क्या हो रहा है?
ये तुम्हारे टकरा क्यों रहे हैं इंस्ट्रूमेंट ऊपर?
इस लिम को थोड़ा ब्रेक करो। एक मिनट सर, होल्ड कीजिएगा। अब देखिए सर,
ये देखो, ये राइट वाला भी पीछे करो, राइट वाला भी बहुत आगे है। इसको जो मार्किंग है ना, ये और पीछे कर लो, और पीछे कर लो, और इसको, हाँ थोड़ा सा। अब इसको थोड़ा एंटी लिफ्ट, इसको उठा के ऊपर करो, इसको हाथ से पकड़ के एंटी लिफ्ट करो, थोड़ा उठाओ इसको।
लिफ्ट अप।
हाँ यस यस यस, ओके ओके, ठीक है। अभी और ये कैमरा को थोड़ा आगे करो, कैमरा को आगे कर दो, और ये थोड़ा सा आगे।
Mic check.
हाँ ठीक है, ठीक है।
ये एंगल को ब्रेक करो।
ये टिश्यू भी आ रहा है ना? अच्छा ठीक है ना, अंदर ही है ना, बस टिश्यू है ना उधर।
हाँ
ठीक है ठीक है ठीक है ठीक है ठीक है। अभी मुझे एक बार दिखाना दोनों।
आप मूवमेंट करके देख लीजिए।
Good afternoon, everyone. Request everyone to please settle down. And all those who are still outside the hall, we are starting with our session. I request them to please grab their most comfortable
राइट,
seats and
लेफ्ट
please be
वाला,
seated.
लेफ्ट वाला कहाँ है?
बहुत एंगल में चले गए आप।
I would also like to request the first 6 seats up front to be kept open for the moderators and the chairperson, please.
अरे ऊपर ठीक है ना? ठीक है। अभी एक बार वो कैमरा को बाहर निकाल के एक बार क्लीन कर दो, और फिर वापस डालो, फिर मैं चेक करता हूँ।
ठीक है, रिमूविंग कैमरा।
वो उसको मेरी आवाज क्लियर आ रही है ना उधर?
हाँ क्लियर है सर।
दिनेश,
हाँ एकदम क्लियर है सर। अब लाइव जा रहे हैं क्या आप? स्पेस है ना?
हाँ
ठीक है, बेटर।
यार तुम्हारा ना वो नजर क्या, ये इसको क्लीन नहीं कर सकते दिनेश? दिनेश
हाँ कर रहे हैं सर, कर रहे हैं।
उधर अरे उसको क्लीन कर दो, अंदर डाल के ना कुछ गोज वोज डाल के फोर्सेप से क्लीन कर दो। उसके अंदर वो पड़ा है ना तुम्हारा यार, वो मसल्स का वो पड़ा है ना, फैट समथिंग, उसको क्लीन कर दो गोज डाल के ना, एक बार क्लीन डाल दो उसके अंदर, फोर्सेप्स कुछ भी करके क्लीन कर दो उसको।
तो टिश्यूज के ल्यूमेन में आ गया है।
और
निकल गया।
और
वेट करके।
दिनेश यहाँ पे ऑडियो विजुअल वाला बंदा है ना, कोई बंदा है?
सर
मैं कह रहा हूँ अगर अपन ये दिखाना चाहें अबाउट पोर्ट पोजीशन, तो तुम वहां से दिखा सकते हो पोर्ट पोजीशन?
अब तो सर डॉकिंग हो गई है सर।
नहीं, डॉकिंग में भी साइड से तो दिखा ही सकता है ना।
यहाँ फोकस कर पाओगे इधर?
पूछ रहा हूँ पॉसिबल है कि नहीं है?
एक बार कोशिश करते हैं सर, करो।
ये एक बार और क्लीन कर थोड़ा सा अंदर से। हाँ अरे रहने दो, उसमें गोज लगा रह गया है। मैं कह रहा हूँ उसमें कैसे क्लीन करोगे उसको? उसको थोड़ा वेट करके फोल्ड करके थोड़ा क्लीन करके कर लो।
ये समझ में नहीं आएगा आपको, डॉकिंग यहाँ से नहीं समझा पाएंगे।
ठीक है, रहने दो, कोई इश्यू नहीं है, वो कल बता देंगे।
पास में जाके कर सकता है?
एक बार देख लो, अगर होता है तो हो जाएगा ना, अगर होता है तो हो जाएगा।
वी वांट टू सी दैट स्किन एंड द ट्रोकार वेयर इट इज।
बस ट्रोकार अरे क्लीन करो। अरे उसको क्लीन करो पहले फटाफट।
कर रहे वो गॉज पीस का टुकड़ा चला गया ना उससे। और अंदर चला जाएगा। नया प्रॉब्लम है।
कैमरा डाल के ही पता चलेगा अभी।
आ गया?
आर्टरी दे दे मेरे को।
यस क्लीन।
ठीक है, डाल दो कोई बात नहीं, अब डाल दो, रहने दो,
थोड़ा टिश्यू
रहने दो, छोड़ो रहने दो, डाल दो कोई बात नहीं, उससे कोई फर्क नहीं पड़ेगा, डाल दो।
वो तो क्रॉस हो जाएगा ना।
ऊपर स्पेस बना के रखा हुआ है ना?
ऊपर मतलब?
बेसिकली आर्म में आपस में स्पेस है ना, राइट कैमरा और लेफ्ट आर्म में थोड़ा स्पेस है ना ऊपर। ठीक है, डन।
ये स्पेस और हो सकता है?
ये यहाँ पे कम है ना कैमरा और इस वाले में।
कैन वी मूव दिस लाइक दैट?
और थोड़ा ये पानी गर्म रखना, इससे थोड़ा कैमरा ज्यादा सीधा थोड़ा क्लीन होता है। एक बार थोड़ा और अंदर डालो, दिखाना
थोड़ा और।
ठीक है, गिव मी कमांड। ओके,
दिस इज ओके।
हाँ ठीक है, बेटर, या ठीक है।
कैन वी मूव दिस, ब्रेक दिस? दिनेश,
राइट वाला लेफ्ट वाला किधर है? ये तुम्हारा देख, ये
एक बार क्लीन करना है।
हाँ क्लीन करो। लेफ्ट वाला पोर्ट मैं देख नहीं पा रहा हूँ, बाहर तो नहीं निकला ना?
नहीं, फिक्स किया हुआ है सब।
फिक्स किया हुआ है, ठीक है।
सूचर से फिक्स किया हुआ है। पुट सम सलाइन।
CO2 प्रेशर, CO2 ठीक है, 10
8 में ही अच्छा था, इसलिए अब
ठीक है, ओके ओके, ठीक है,
8
no
पे ही है,
problem.
फिर
ठीक
हीमोडायनामिक
है,
थोड़ा वो हो रहा था ऊपर।
ठीक है, ठीक है, ठीक है, ठीक है, प्रेशर कितना 100?
100 प्लस है।
ठीक है, ठीक है, ठीक
ये अर्जुन सलाइन अटक गया है वो।
है। देना मुझे। जब लाइव जाएंगे तो कैसे पता चलेगा अपने को अंदर? है
ये लोग आपको कनेक्ट करा देंगे।
कनेक्ट कर देना लेफ्ट इंस्ट्रूमेंट।
Good afternoon, everyone. I hope everyone had a great lunch. We're just going to wait a few more minutes for everyone to get settled within the summit room. In the meantime, I would like to make a few housekeeping announcements to note. Refreshments will be served outside due to regulations at Bharat Mandapam. It will not be allowed within the hall, unfortunately. And please be mindful of your time slots and keep an eye on your moderators for regulating the dialogue. All questions and answers will have to be saved for the panel discussion later, and we'll be adjourning the
Clash,
session
sir,
by
clash.
4:30 p.m. as there will be a faculty dinner. The buses will leave by 5 p.m. in front of the Bharat Mandapam.
दिनेश कर रहा है।
अरे दिनेश, ये क्लैश क्यों कर रहे हैं? तुम दूर क्यों नहीं कर रहे हो? कैमरे, ये कैमरे से टकरा रहा है, तुम्हें समझ में आ रहा है?
हाँ 1 मिनट सर, 1 मिनट। एक मिनट सर, कर रहे हैं। इसको थोड़ा इधर कर नहीं सकते? उसको भी करो ना। नाउ द लेफ्ट। पूछना बोलना कुछ अर्जेंट है तो बात करो। मेरा परफ्यूजन इस पर पूछना कुछ अर्जेंट है तो बात।
क्या हुआ? ठीक है अभी?
कर रहे हैं सर, 1 मिनट बस। This portion needs to be करो।
दूसरी साइड करना पड़ेगा ना।
क्या क्या प्रॉब्लम है मुझे बताओ ना।
सर वही लेफ्ट आर्म और कैमरा में क्लैश हो रहा है।
यार लेफ्ट आर्म और कैमरा में क्लैश हो रहा है तो ऊपर उसको, उसका जो डायरेक्शन है ना, उसको ऊपर से, उसको जो है ये ब्रेक करो ना, उसको ब्रेक करके थोड़ा दूर कर दो उसको।
हाँ, वही कर रहा है, वही कर रहे हैं।
अब कैमरा वाले को उस साइड करना। हाँ बट ये अगेन हो जाएगा
इसको
हो गया सर।
शुरू हो जाएगा, फिर होगा।
थोड़ा गैप चाहिए, नहीं हो।
मेरे काम का तुम इंस्ट्रूमेंट निकाल सकते
सुनो सुनो, पहले इंस्ट्रूमेंट निकालो, दोनों को करो, फिर दोबारा इंस्ट्रूमेंट डालो। सिंपल सिंपल चीजें रखो, ये इंस्ट्रूमेंट से तुम्हारा समझ में नहीं आ रहा। एक बार ये इसको राइट कोटरी को भी निकाल लो, स्पैचुला को निकाल लो।
हाँ निकाल रहे हैं।
हाँ, और उनको एक वाइड स्पेस बनाओ, को बीच में रखा है, इन दोनों को तोड़ के इनको स्पेस बना दो और देख लो कितना दूर से साइड से आएंगे वो दोनों।
नहीं तुम्हारा ये एंगल इसको उधर नहीं ब्रेक कर सकते।
इनको मेरे ख्याल से किसी बंदे से, इसका कौन है वहाँ पे, वो है, क्या नाम है, दिनेश है जो आपका बंदा है, उसको किसी से कनेक्ट कराओ ना। ये क्या नाम है जो उनका, क्या नाम है, किससे कराओगे? मनीष वगैरह से किसी से कनेक्ट कराओ ना। मनीष समझा देगा ना क्या करना है।
Ladies and gentlemen, welcome to the third Global SSi Multispecialty Robotic Surgery Conference, SMRSC 2026. Welcome to the summit room at the beautiful Bharat Mandapam.
And welcome to the cardiac track. For those who are joining for the very first time, a very warm welcome. You're exactly in the right place.
And for those who have been with us at SMRC before, welcome back. I'm Dr. Abrami Babu. I'm the Chief of Staff and Director of Medical Affairs at SSi and SSi CRS. And alongside me is
Dr. Azra Khan, and I'm the host for this summit. It is our honor to be a host for what happens in this room for the next 3 days.
What a morning it has been at the inauguration ceremony, certainly
वही
setting
बोल
up
रहा
the
हूँ, वही।
scientific stamina for the next 3 days. As Dr. Fred Moll said,
Not this one, but
robotic
left.
surgery started with the heart and landed on the prostate.
ऐसे आ रहा
But
है
it's
ना,
fair
ऐसे
to
आना
say
चाहिए।
with Dr. Balki's leadership and Dr. Sudhir Srivastava's legacy, we are definitely getting back at the heart.
And the next 3 hours, you will witness live robotic cardiac telesurgery across 2 hospitals simultaneously,
Now looks better.
streamed into this room in real time. You will hear from some of the finest cardiac surgical minds on this planet. Last year, we inspired, but this year, we aspire to transform.
So chairing this session today is the Professor of Surgery and Director of Robotic and Minimally Invasive Cardiac Surgery at University of Chicago, a pioneer and the present leader in robotic cardiac surgeries. He needs no introduction really, our chairperson of this entire cardiac track, Dr. Sam Balki. Please give him a round of applause. And moderating alongside him is Dr. Nitin Rajput, Dr. Harish Badami, Dr. Yugal K. Mishra, and Dr. Anil Mulpur. Please take your seats in front and let's start our session.
दिनेश
हाँ सर
दिनेश
बोलिए।
ये क्या क्या मेल पेशेंट है क्या है कितना कितने साल का है
मेल पेशेंट है 57 इयर्स
टीवीडी
टीबीडी
एंड एलईडी ओएमपीडी है
Good afternoon, everybody.
ओके
Lalit, can you hear me?
यस सर
Ah, good afternoon, Lalit. We
गुड
hear you.
गुड आफ्टरनून सर
Okay, well, welcome to the cardiac session at the SMRSC meeting number 3. It's
क्या
great
कर
to
रहे
have
हो?
everybody
Oh.
here. Great attendance on the cardiac side. Lalit, you've been speaking not in English, so I have not understood a word you have said. And,
sorry sir
it's-
basically I'm talking to Dinesh other side Puttavarthi.
So, can you introduce the team over in Puttaparthi?
sir yeah in Puttavarthi we have 2 cardiac surgeon there Dr. Dinesh Chandra and Dr. Tania and other we have a staff on bedside nursing staff is Dinesh and this patient is plan for robotic assist CABG. This is a male patient of 58 year patient have a TVD and plan for maybe lima harvesting or maybe lima harvesting depend upon the situation and rest of the vein graft and by after that small thoracotomy and then complete this robotic assist CVG.
Great. And where are you sitting?
Just where I finished my lunch, just downstairs.
So you're downstairs from where we are.
Yeah.
And
Oh,
the
yeah.
patient is in Puttaparthi. How long of a distance is that?
I exactly
दिनेश
maybe
Recording
near
in
about
progress.
It's about
2000?
1,400 kilometers from here, Delhi, sir.
yeah,
1,400 kilometers from Delhi.
1,400. Yeah.
By road, by road.
Okay. Can you raise your hand in the room if you've actually witnessed a telesurgery before? Raise your hand if you've seen a
Dinesh, can you show me the all instrument?
So this is in a cardiac
Dinesh?
surgery room. I didn't
So,
expect
2 minutes,
to
sir,
see a
set up
lot,
kar.
but it's been done in urology and general
बाहर निकल
surgery.
गया लग रहा है
So this is also considered groundbreaking.
Yes,
Many
जल्दी में निकलो।
surgeons would be abhorrent to see this because there is no control. But I think the capabilities of the system and the significantly low latency is a feature here is what
पूरा अंदर ही
allows
रखो,
this to
फिर बाद में
happen.
under
And I
vision निकाल लेना।
experienced this when we were in Strasbourg
उनको
last
पसंद है।
summer.
Dinesh,
I didn't do a
don't put
live
so
case
much
because I don't
inside.
have privileges in India, but I was able to use the SSi
कैमरा
system
कैमरा लिटिल बिट
um,
आउट
on a cadaver
When
in
we clean the
indoor,
camera,
and
when we put, there
we
was
just
some
did
muscle
harvesting and TCAV and whatnot. So Lalit, we see that there's some adhesions on the upper lobe there on the left
Yes,
side.
yes, sir. Yes, sir.
Planning to take those down?
Yes, sir. Basically, they are going to put cautery and bipolar, cautery and bipolar forceps on left, and we have actually very new team in Puttavarthi, and so maybe they are
Yeah.
going to put here. So maybe we have this. They take some little time,
I
but
see.
it's okay. Yeah.
So
but
you
it's
have in
okay.
your left hand a micro bipolar,
Yeah.
and in the
yeah.
right hand, the spatula?
Yeah. Right hand is spatula.
If I may suggest, the ports are a little bit deep from what I
Yeah.
can see.
Yeah. 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 Yeah.
Including
yes.
the camera might be a little bit deep.
Dinesh.
हाँ सर बोलिए.
Yeah. Don't put inside. Don't put inside. Don't put. Don't go. Don't go.
Outside.
Yeah.
Pull it out.
Okay. Give me. Can you give me command?
Yeah, so you need control.
Give do-
And pull trocar little outside, please. Pull trocar both. Camera, yeah. And give me command. Yeah. Little pull this camera.
Out.
Camera. Yeah. Camera. Little camera. Camera port little out.
We call it burping
More.
the camera out.
Little. Yeah. Little pull out this. Yeah. Camera port.
Go
Yeah.
in. Go in. Go in.
So you can see, for those of you who have not seen the robotic view, I know there's some experienced robotic surgeons in the room, but this is the view that
Okay,
you would
okay.
get.
Now give him the control.
Yeah. Give me control. Yeah.
What's your CO2 insufflation there?
I think they started with 8 maybe Hg, and flow is 8,
Good.
and yeah, 8 ml per minute, or maybe we increase up to 10 or 12 according to the situation. Give me command, please.
Yes, you are having.
Okay.
Okay.
So now I have a command, and this is my so here the yeah, Lima, this
Yep.
one.
There's the Lima.
Yeah, and some adhesion is there. So I think first,
Take the adhesions down.
yeah, first we'll go this adhesion down. Yeah.
Is this a smoker or a city dweller?
Then it is
Smoker. Smoker.
a smoker. Yeah,
Smoker. Yeah.
yeah. Give me Kotri on 30 or 20.
25.
Yeah.
Yeah, sir. Done, sir.
Cautery 30.
There it goes. And you're planning 2 IMAs?
It depends, sir, because I think maybe if everything is okay, then we go for 2 IMA. Otherwise, Lima only. Because the problem, not a problem, because my specs, I have a progressive lens, and basically they make this lens for this 3D glasses is only small, this near vision, not progressive lens. Maybe this is a little problem here. Because I'm wearing this
30 कर दो.
glasses, this glasses have a 3D vision from this, and they add my Cotry 40. Can you add 40?
Yeah. Cautery increase to 40. Yes.
How are you doing that? You just changed the horizon. That was a good
Yes.
move. How did you do
Extreme
that?
Yeah.
degree में जाएंगे.
Basically, this I have a control with the pedal, and I press my right foot on the pedal, and then move. I have a control here, all control I have,
Okay.
and because by this pedal thing we can change instrument by Cotry, or if we want to change the position of our hand, so we press clutch and change the position of our hand
Yeah.
easily.
Right.
इतना ऊपर जाने की जरूरत नहीं।
So you're planning multi-vessel mix after this?
Yeah. This after that.
Actually बहुत इधर आ गए हमने इसलिए भी हो रहा
Uh,
है। So we can leave this.
Any questions from the audience that you'd like to
Uh,
ask? Lalit?
for the audience, and the port placement is 246 this is for camera port, we choose fourth intercostal space, anterior to entry exit line 2 centimeter.
Yep.
And for right port, we choose little anterior to camera port in second intercostal space, and for left this bipolar, we choose 6 intercostal space, same line to the camera. So this is our marking of port placement.
Yep.
So every time we open posterior pericardium, just posterior to, this is phrenic nerve.
Yep.
So here for phrenic nerve, so we open always this pericardium here. So it's better to drain out. So give us post-op drainage, blood drainage, and for lima that's give us some space. So it's always better to open. Can you cautery 20?
Yeah, cautery 20 please.
Yeah.
Just hold on.
Yeah.
Yes, 20 now.
Can you hold respiration for a while?
Lungs down.
You have a bronchial blocker or a double lumen tube today?
So we are using bronchial blockers.
We always use bronchial blockers. Sometime we use double lumen, but most of the time bronchial blocker, I think it's easy. And if patient not maintaining saturation, then sometime we open also to that blocker, because CO2, ongoing CO2 also compress the lung.
What angle is your scope?
Basically, in my setup in Jaipur, I have all 30 degree, 30 down, but here in Puttavardi, we have only 0 degree, old this one, but I have both old and new one, this 30 up, 30 down. So basically, in my center, I am doing this step with 30 up, because for lima we use 30 up, and for lima LED harvesting 30 down. But here I'm using 0 degree. So
you're going to start with the left IMA?
yeah, left IMA, or we can go.
Single lung ventilation can be on.
I think from another OT from Gurugram, they are harvesting double IMA. What's the plan?
No, the other case is actually not happening. Dr. Yusuf is here with us watching you.
Okay.
So
So-
you're our only live case this afternoon.
Okay.
You know what my recommendation would be, right?
Yeah.
Is if you're going to take the Rita, take it first.
Yeah, okay. If we will go for bilateral, then go for, yeah.
Only if
Yeah.
you're going to take it. If you're not going to take it, then you take the Lima now. But the reason is because you might injure the left IMA if it's hanging low. And
Yeah, but
that's-
so we basically, I think because so we plan go for Rita. Otherwise, I think I go for only Lita.
Oh, okay. If you're going only Lita, then no need to open the right pleural space.
Yeah.
Yeah.
Can
Dr. Boyle,
I think-
is-
Dinesh, what do you think? Is you harvest vein or what do you think, Dinesh?
Sir,
Dinesh Chandra?
we are okay with both. आप decide कर लो.
Because I think some problem with you put this port things. I think can only harvest this Lima thing is okay.
Okay, sir. Okay.
Hi, Dr. Boyle. I got a one question. Rajita from Sri Lanka. Hi, Malik. Lalin.
Yeah, hi.
Just
Hi.
wondering, when you take in the right memory, you take from the right side or from the left side?
The
I heard
same.
there are some people who take from the right side as well.
No, sir. Basically, what I learn from only from left side. Same like in thoracotomy cases. I go for only for left side. Only Dr. Yusuf go for both side. But I go on for left side. Can somebody ask Dr. Sudhir sir what the plan? You go for bilateral or this one? This patient? Yeah.
So he does it all from the left side. The majority of people, when they harvest bilateral, are going just from left-sided ports because it's
Yeah.
easier. Dr. Yusuf is the pioneer of bilateral docking.
Yeah.
We've done bilateral docking when
Sound, thoda sa. Can you reduce this sound? Reduce. Right, yeah.
we've done bilateral docking when we want to graft the right coronary with the Rita.
Right.
So we'll harvest both from the left and then dock on the right side and do a Rita to RCA potentially.
Right.
Not a lot of cases, very few cases.
Yeah, but if you're taking the right side, Dr. Boyle, you have to take the right side first, right? Before
Yeah,
the,
if you're going to
before
come
the-
in from the left, take the right side first and then come back and take the left.
Is it more approachable and easier than the mixed surgery when you're doing robotic? How is it
Very much so.
yeah.
Very
What's
much
the reason?
The
for
CO2 insufflation, you have a tight CO2 environment, the heart is away, you don't have to retract. You know, there's a lot of times I see the mixed cases, the heart is right up against the sternum, and in this case it's not. Obviously the visualization, the 3D and the dexterity are speak for themselves. So I think that it's definitely easier than in a typical mixed case.
And skeletonized as well, I suppose.
Yeah, I prefer to skeletonize. I think it's easier to skeletonize with the robot, and once you've skeletonized, it's easier to handle the conduit, especially if you're going to go for a TCAP.
Thank you.
Yeah.
Dinesh, how much is cautery?
20.
Okay.
You want to tell us your approach, Lalit? Do you uncover it first from the top to bottom, or do you get into the fascia, or how do you do?
Basically, yeah. I just follow the same rule. What I am doing this thoracotomy cases, separate first fascia, clean the lima, rema, then then again start with the separate endothoracic fascia, cut the muscles, and then I start where more visible lemma, maybe second or third intercostal space, and go first proximally and then distally. So, and depend upon the patient. If I prefer only lemma takedown, robotic assist CVG, I go for skeletonized. But if in my practice, if I plan for TCAP, then mostly semi-skeletonized and leave it one or two places attached as separate later.
So if you're going to do a TCAP, you do semi-skeletonized, and if you're going to do a mixed cabbage
Recording stopped.
Yeah.
or mid
Yeah.
cabbage, you'll do
Yeah, mostly,
Medical.
mostly so. Yeah. This is depend. Sometimes semi-skeleton also in robotic assist, but it's depend upon the patient. But most of the time, this is my strategy actually.
एपेक्स पे जब उधर तो जाने की जरूरत नहीं.
How's your feeling of the latency here? Do we have a number?
I don't know, but I think I don't feel anything. I same like I'm sitting in my main console, and I think maybe latency less than 50 maybe millisecond. I don't know what the exact figure. The technical guy maybe tell us.
Yeah.
So basically I separate, and this here the phrenic nerve, basically this is our actually landmark. So come here, and normally I stop here. So this is our landmark phrenic nerve here. दिनेश ये हिट हो रहा है कहीं ऊपर, मे बी प्लीज चेक दिस हिटिंग समवेयर, या कैमरा हिटिंग समवेयर.
एक्सट्रीम अप में सर वो लेफ्ट पोर्ट से हिट.
I will play this when I saw your case, sir. When I was in Chicago with you for cases, so I saw you. You are very particular about first branch or medial branch.
Yes.
Yes.
Are you going to divide it?
Yeah.
There was an interesting argument at ICC about the branches of the IMA.
Yeah.
Whether or not one needed to clip all of them or you could leave a couple at the top. My contention is that one should clip all of them so that you avoid runoff and steel. But some people were saying because the flow into the myocardium is in diastole, it will preferentially get all of the IMA flow, and the flow into the first intercostal branch, for example, is under systemic pressure, and therefore it won't. Who agrees with that? Who thinks that you should take all of the branches? Raise your hand if you think you should take all of the branches. Raise your hand if you think you should leave the first intercostal. Okay, good. So we're in the majority. And it's not easy when you're doing a sternotomy harvesting or a mixed case harvesting to get to the very top. I take pains, as he was mentioning, he came and visited me a couple months ago, to get all of the branches, bar none, even on the right IMA from the left side. And I think one of the reasons that Dr. Yusuf goes to the right side to harvest is because of those branches. It's much easier to get it when you're exposing from the right side. So I think that all the branches should be gotten, but it's harder when you're doing it from the left. Do you want to say something about that? From the left, yeah. I think Yeah. Using a third instrument to push down the anterior mediastinal fat really helps in getting to the very top of the right IMA. And if I see an intercostal first branch, I will go beyond and really cut the pleura all the way up there, obviously taking care not to hurt the phrenic in order to get that thing, even if I get it distally, not right on the IMA, but in the middle somewhere, wherever I can see it. Yeah. And so that's how we do it. I put a stabilizer. Because, yeah, we have the stabilizer and we're going to do a TCAP anyway, so the stabilizer is already available there. And I don't get the top part of the right IMA until the stabilizer is in. And the stabilizer doesn't go in at the very beginning. At the very beginning, I put 3 ports just like this and use 3 to harvest. And I'll show a video tomorrow, I think, in my talk about that. The stabilizer is what allows you to do that. Otherwise, I don't think you can. Mark Ruel has been doing it without the stabilizer, and he uses a long tip forceps or a dynamic atrial retractor on the XI system to push it down a little bit. But I don't think it does the same job. I think the stabilizer has a broad base and it can really spread and push down, and you won't injure the innominate vein. It's a broad-based instrument.
I got two. You cut the vein, the first vein, the vein that crosses across.
Always, always.
Therefore, you get extra length. Across.
Yes, always.
The other thing is that I spoke. I spoke to somebody and he told me that he takes, when he's done an MICS, normal MICS, he takes a remark, stitches on the pericardium and drops them out skin.
Yeah.
Pulls the remark of the pericardium this way.
Yes, I've seen that. Yes, I've seen that, yeah.
You've never done that?
No, I don't need to because I have CO2 insufflated, so everything is down, and if it's a little high, I put the stabilizer. So I never use pericardial sutures in my coronary cases, only in the valves because of CO2.
Yeah, I tried that once. I was scared of getting through the right atrium. I thought I'll puncture the right atrium.
Yeah, because it's so far away. Yeah.
Parky, I know you have worked with this system, maybe not live, but in the labs. So yesterday when I was practicing to do this, I found the movements were more out of my control compared to Da Vinci, which I've been regularly using. What is your experience with that? Because Lalit, I think he hasn't used Da Vinci much, so I'm not sure what he feels. But
Yeah. Well, I can let Lalit speak for himself, but from my experience, and I've been on several generations of Mantra, it's the controls currently are so light that when you're used to the resistance on the Da Vinci system, it becomes a little bit, it feels funny. And sometimes you don't have enough weight against your fingers to move. Yeah, so it just takes a little getting used to. Lalit, can you tell us about, you've done some Da Vinci a long time ago, but mostly your experience is on the Mantra, correct?
Yeah, basically, I have experience only Da Vinci. I saw some cases with Dr. Misra sir, but I never did a case. So as a case part, I have experience with only SSi Mantra. So it's difficult to me to comment on that about case. But I think I learn only this system, how to things going on, how to operate this robotic things, and I feel very comfortable. I think this is a one step ahead to because we are doing more number of cases with MICS surgery, thoracotomy, so it's very easy to change to this robotic things. I think this is our point.
So Dr. Balki, I used Da Vinci when I was in the US a bunch. I've done a few 100 cases, and then since we were the first Apollo hospital to actually get the Mantra, I've done about 10 of these cases now. So like what Dr. Yusuf had mentioned, one is you're sitting in the open, as opposed to when you're in the Da Vinci, I almost feel like I'm safe once my head goes in there. as opposed to here, you're sitting out, everybody can see you, your facial expressions, everything. And the other thing that, now that I'm doing more cases is if you hit the clutch button and if your hand moves, the moment you release the clutch button, that movement translates. Which initially when you use, you don't notice it as much, and I don't know if that's what you were feeling, but when you're doing the dissection and you're holding something and then now you've just sort of clutched, moved the camera, if whatever you're holding, if you moved your hand a little bit, and remember now with the Mantra 3, your hands are not on a gimbal, right? Your hands are free. So they could move, a micro movement, but then all of a sudden a 10-time magnification, like you're holding the memory and the hand just moves.
Yep.
So that part I thought was a little scary, but I mean, it's, he's not doing it. I've been watching his left hand. He's had it steady. So I think once you get used to it, then you don't make that movement, or if you're going to hit the clutch, maybe let go of the memory. But then the hardest thing is when you come in with the clip, right? So you're holding it and then you asked for the clip and then they've moved it. You're trying to look at the clip. Now you've come back. You're thinking you're still holding. The moment you release the clip, there is a little movement with your left hand. Which is,
That's interesting. Lalit, did you
Yeah.
hear what he said?
Yes, sir. I think, sir, basically, in initial cases, maybe this was happened in initial cases, but when you after some 20-25 cases maybe, or when you are doing regularly, I think this the chance of these things are very less.
Yeah, but I think you described it very well, that it's not, your hands are free in the air. In addition to the fact that you're out of the console and you're exposed, but also you've got no restrictions. Your hands are free. And I think that's one of the biggest challenges in the transition.
I think that's what helping the non-cardiac surgeons who, laparoscopic, it's the same thing, everything's in the open. So that's why I've seen our general surgeons and our gynecologists are definitely, the laparoscopic guys are having a better time at it than I am.
Yeah, I think it just takes a little bit getting used to, and if you've used Da Vinci, then it's going to take you a little longer to get used to it. So you're making some good progress there, Lalit.
Basically, yes, sir. I'm going to separate this digital part. I prefer always expose a lemma, and most of the time the distal part here I'm not open pericardium anteriorly. Otherwise, I open anteriorly pericardium, and if I feel this proximal lesion, I never go more distally. I think this length is enough for me, and that save time for me.
Yeah. Are you going to use clips on the branches?
Yeah, definitely, sir. Only basically, sir, if I plan for robotic assist CBG, I use only few clips, big branches, and when I open thoracotomy, then I apply some clip later on, if I feel. Otherwise, in TCAP, yes, most of the time I applied clips.
ठीक है दिनेश जी
But yeah.
Go ahead, Lalit. Go ahead.
Yeah, but I tell you, sir, basically the movement I feel same like in my OT. The thing is because if always good to always operate with your team is give us confidence, and actually some hitting camera sometime to my right or left arm sometimes. So basically that's why, and my glasses, I think not ready for this one in inbuild this 3D glasses. That's why I prefer go for Lima today only. This why. Yeah.
हो गया इंजरी
Looks like a vein.
Yeah.
Yeah. So there's a question of, is there a better way to open the fascia, and would you open it with scissors? I think I wouldn't open it with cold scissors. I would open it with electrocautery, whether it's bipolar or like this one, the monopolar. There's a technique that Wouter Oosterlink from Leuven uses, and it's a bipolar, similar to the thoracic guys, and it's a nice technique. It's pretty quick, and I've seen the arteries that come out of that very clean. But sometimes when I think about trying it, I don't know. I just figure that he chooses the right patient, because sometimes there's so much inflammation around the artery and so much fat and such. It's hard to do. Have you tried that? The bipolar? You've tried it?
247 बेटर होगा ऊपर होगा तो काफी स्पेस है
Nice. With the bipolar scissors? Or sorry, the monopolar scissors? Yeah, yeah. The electric scissors. Yeah.
Often we can keep it together, but urologists always do that. They don't use spatula, they just use scissors.
Yeah.
So then seeing that,
You can do that. Yeah.
What I did was that I tried to start
डॉक्टर ललित कॉटरी इज ऑन 20 चेंज तो नहीं करना है
when I put it
It's
from the
okay.
top, I couldn't come downwards. I mean, I started from the first rib, second rib, coming downwards. It was difficult because you had to come backwards. Like that.
Yeah, coming back is hard.
So I started from below up,
Nice.
and then I could do it quite easily.
With the left hand?
डॉक्टर ललित क्वेश्चन फ्रॉम आवर ओटी वन यंग सर्जन वांट्स टू नो व्हेन इज द राइट टाइम टू स्टार्ट रोबोटिक
Dr. Arun.
For a young surgeon.
You prefer to use the bipolar
Okay.
for taking down the fascia or monopolar? Which one would you?
Monopolar.
Monopolar.
Monopolar, yeah.
Yeah, monopolar.
For skeletonized also.
Wait, what's that? Said?
For skeletonized also.
Yeah, for skeletonized also. At 20.
At 20. Okay. I've seen some surgeons use with the Da Vinci cautery of, that's with power of 8, and then take down the fascia with the bipolar.
Yeah.
Having it initially, like Dr. Lalit was saying, initially in the left, you start with the middle, and then probably towards the end you move it to the, hop the arm to the other side, and then take down the inferior side. So,
Can you give me a clip?
Yeah, that's Dr. Oosterling. He described
yeah,
it.
yeah.
Giving.
So, the bipolar cautery, it transmits the heat both the sides, right?
That's a good question. We've never proven that. I've asked the engineers all the time. I wonder if we can ask the SSi engineers while we're here. The premise is that only on the inside is where the heat is. But you have to assume that the outside also feels it.
The overall instrument should get heated up.
Yeah, it should get hot on the outside. So if you're touching
Cautery.
the IMA, then you're going to eat it when you do that technique. But the way he does it, Wouter, he doesn't use clips at all. Or very rarely on just one large branch. But in general, he'll just use bipolar on everything.
Have you felt any latency with the Da Vinci system itself, even though it's close?
Not really. Maybe I've gotten used to it. I've been using the Da Vinci for over 20 years, but I think when you're in the same room, it's hard to perceive it to some extent.
Sometimes I feel like, especially with the movement of the camera, there's a certain lag when you start the movement and then it's transmitted a little, the very slight delay
With Da Vinci?
with Da Vinci.
I have not seen it. No clips?
They just use the bipolar for
For
all the branches. And
Even the big ones.
We don't,
It's quite scary for me. But,
Me too.
We don't use clips also.
Wow.
Like we use, most of the time it's pedicle, and we don't use clips very rarely. say like around 200 cases, and we have used 30, 40 clips. The first
it's not
set which
open
he gave, it's still there, so
It's a
very rarely.
cost-saving maneuver as well.
Probably. So, but
Dinesh.
after the mini thoracotomy is done, you go in and clip the larger branches.
I see.
The Da Vinci monopolar is so good that even small tiny branches you can just take it off even without doing bipolar. Yeah, after you do a mini thoracotomy, as he said, we can just clip it. And opening the fascia with a bipolar, it's a beautiful technique. I think popularized by Luca. Oh, the trick is you don't grasp it completely and do the bipolar. Start doing the bipolar with one arm and then gradually pinch it so that the tissue won't adhere to your bipolar, the jaws. That is one thing. Otherwise, the tissue gets stuck and it will lead to avulsion of the mammary sometimes. Keeping the cautery at 7 or 10 will really help. And any tips or tricks to avoid hitting of the left shoulder, the right arm? Sometimes as you go distally, almost at the bifurcation, sometimes the right arm hits the left shoulder.
Yeah.
Any tips to overcome that?
Yeah, that's a common situation that people get into, and there's no real solution other than if you see a prominent shoulder, to put your port not in the second but in the third, and maybe a little bit more posterior so you avoid it. And the second most important, or the first most important thing is when you put a roll under the shoulder, not to make the roll too high, because if the roll is high, it will raise the left shoulder. And then also make sure that when you're positioning the patient, to pull the patient off the table just a little bit so that the shoulder drops. So those are all little things that can help bring the shoulder down, but there will always be a case where you're just struggling, and sometimes I have my assistant place put their arms on the shoulder. But yeah, it can be painful. The other thing that sometimes you'll get into is it's not a conflict with the shoulder, but it's a conflict with the rib. And you can easily go in, undock, take the port out through the same incision on the skin and just relocate it to the interspace below, and that gives you access over there. Sometimes I'll intentionally do that when I have a very long torso, long chest, and we're working on the distal third of the LAD, and I know that I'm going to be sewing down there and it's so far away and the angle is going to be like this. I will intentionally start with it above the rib, harvest the top, and then when I come to sew, I'll take it out, put it in through the third interspace. Same incision in the skin, but and the concept there is not that that should be the way to do it, it's just that that's an option. And always think of the little things that you can do to make your life easier. Because otherwise that rib can really hurt you, and then it'll hurt the patient post-op day one.
Yeah, that's a nice technique. You also shift the camera port down?
Not always, not necessarily, but I had a case just last week where it was a lady with very difficult exposure, and I shifted both, just like what you said. I shifted the right hand and then I shifted the camera down.
Because I know like Da Vinci Xi doesn't have stabilizer, for example.
Yes.
So, but Mantra 3 system has everything you need for a TCAP from the beginning.
So there's two instruments that you need for a TCAP that the Xi does not have. The Xi is the 4th generation Da Vinci, and that is a stabilizer and the snap-fit arteriotomy blade. The SSi Mantra has both of those things. And Lalit, can you tell us about your experience with TCAP on the SSi?
Yeah, we started after some Rima harvesting. We started TCAP program with SSi Mantra, and we feel this Indo stabilizer very good actually, and we did near about 18 this TCAP things, and sometime, and Initially, we started only Lima LED, and still we are on Lima LED. But when I visited to your place, and sir told me many times, try to this OM also, but we are waiting for right patient actually.
And the stabilizer works well for you?
Yeah, basically in stabilizer, the good thing is we have everything: stabilizer, negative suction, and saline. We put saline through that, and we can easily do anastomosis. Maybe tomorrow I will show you how we put our stabilizer and what's our technique actually.
Excellent. So we have on the agenda three or four talks, I believe, and I was wondering if this would be a good time to, these are virtual talks from faculty that could not be here. Oh, we've canceled all of them. Oh, so we can just have a chat. Okay, so no virtual talks. Get it.
And about the NADI, this device for, do you have any experience?
No, it's not available yet. It's in development. But I have experience with a similar device called the Seaport, and I'll be talking a little bit about it in my talk tomorrow.
I believe it's for laboratory and somewhere could be.
Oh yeah, it will be available for both open and closed chest. It's a micro stapler.
Dr. Balke.
Yes, sir.
One question from Puttavarthi.
Yes, sir.
They are saying, so they want to ask you one question. When to young surgeon, when they start, if they want to start cardiac program, what do you feel? When they start?
When should a young surgeon start a robotic
Yeah.
cardiac program?
Yeah. Because my assistant Dinesh and Tanya, they want to ask this question.
Yeah, that's a good discussion. I'm giving a talk on that tomorrow.
Okay.
But we can maybe, have a little bit of a conversation on it. I think it depends on where they are. So if you have a junior partner in your unit who is working with you already, then that's a different story than somebody who just got out of training and wants to become a robotic heart surgeon, but is not in a unit that does it. Those are two different things. And so I think the first thing to say is that it should be customizable as to how to get there. And in my mind, I think that doing a fellowship after your formal open cardiac surgery training is necessary in this day and age. It may not become necessary later on when everybody is using the robot in all the different specialties, but I think a fellowship is probably necessary. And then the question is, what do you start with? Do you start with IMA takedown? Do you start with valves? Again, it depends on what you can do or what you've learned. My recommendation to the young surgeons today is to go out and do the things that you learned how to do in heart surgery as a resident in training, get some experience under your belt, get into trouble, get out of trouble. If you're destined to be a robotic coronary surgeon, I think learning OpCab, which in India may not be as big of a deal as it is in the United States and in Europe maybe, but I think OpCab is a very important precursor to TCAB. And so those are some of the things, but I think it's, the answer to the question is very customizable as to what you have done and what you are doing.
Yes, sir. Definitely, sir.
डॉक्टर ललित एक बार एक पोर्ट को लेफ्ट पोर्ट बाहर आ गया
Okay, you put and basically change this bipolar. Yeah, not open properly. This not open properly. Left is not open properly. Change and ये the and
we are
oh
changing-
क्या कर रहे हो क्या कर रहे हो क्या कर रहे हो अंदर निकालो निकालो बाहर निकालो उसको.
We are changing that instrument.
Okay.
I don't know about the other procedures, but when it comes to when it comes to mammary harvest, I think it's very, very difficult to injure a mammary when you are harvesting robotically. The visualization is so good. And now, once you get accustomed to mammary harvest robotically, going to MICS, direct vision mammary harvest is really, it's a pain, what I feel. So, yeah, for mammary harvest, once you get a hang of and how to maneuver the instruments, I think you are ready for it. But other procedures, yes, it depends on individualization.
Yes, sir. You're right, sir. Actually, I tell you my experience because we are doing MICS CABG from last 7 to 8 years, or sometime in a day 2 or 3 MICS case I posted in my OT. And after 3 or 4 days, there is lots of back pain or neck pain. Big, not about surgery, this is about lima or rima down harvesting.
We are ready, sir. We are ready.
Yeah, Cautery 15. So this is the basically issue to harvest because we have to move our neck lots to harvest lima rima, and so this is not there's and after lima rima is I think is a time of 1.5 hour or sometime 2 hours for all 3 or 4 grafts. So it's and I think this is the part of pain of our side. And other thing is when we are going for a rima or lima harvesting to thoracotomy, then there are lots of retraction and sometimes there is a fracture in the ribs. So there is a pain for the patient after in first visit or second visit. So I think, but when we harvest this robotic things, so pain very negligible to the patient. So I think this is the main reason to shift to MICS on robotic things, sir.
Yeah, I think I agree with that.
थोड़ा बीच में ब्रेक करो, क्लैश हो रहा है. डॉट मुझे बोला करो पहले करने से पहले. इट्स ओके दिनेश?
हाँ ठीक है.
ओके. Break your this left arm away from the camera. Can you put this here? Yes.
Were you not able to do that yourself, Lalit?
Basically this is the problem from outside, from the arm clashing there, sir. Not, but I can't do these things from here actually. Okay.
आर्म को इधर करने बोल रहे हैं. जैसे ये एंगल है.
Like on a predictive future thing, how do you think, how disruptive will telerobotics be for the future of surgery? If I'm sitting here doing an operation 1,000 kilometers away,
40-15.
what's the other guys going to do 2,000 kilometers far?
1.5.
So Lalit, there's a question about telesurgery.
Yeah.
And how disruptive it's going to be. If you're going to sit there and do it from 1,000 miles away, what's the other guys going to do at the other institution? That's the question.
Yeah.
I have an answer, but you go ahead.
I think this is a part of benefit for the patient and benefit for the surgeon to learn things. Actually, this is a step-by-step approach through the telesurgery. Maybe this is the main reason, and is easy to learn and good for the patient also. So I think this is only my point.
I think I agree with you in that the expertise comes from the person, from you, if you're at the center, And you're not only doing the surgery, but you're also doing the tele-proctoring and the tele-teaching. And so eventually it'll result in a transition where the local surgeon can then start to do the cases themselves. So I think that's one of the benefits. So that's disruptive in and of itself, in the fact that you can impart expertise, not only as part of the therapy, but also as part of the training and the education. The second thing is that in a world where, as you saw the numbers this morning, you know, the majority of the world's population does not see robotic surgery or get anywhere near it, I think there's some significant benefits to it. Now, in a world like in the United States, where telesurgery is going to take a long time before it gets to us there, I think the potential first case uses might be in a medical system that has multiple satellite hospitals, that it will be financially beneficial for them to not populate each small hospital with an expert, but to have the expert in the central hospital and then provide the services elsewhere. You could say, well, you know, if it's not that far away and the satellite is only a half-hour drive, why wouldn't the patient just go to the main center? There are benefits in terms of keeping the main hospital not saturated with patients, and so so for example, if we consider a Lima LAD as a relatively simpler, if you will, operation than a more complex cardiac procedure like an LVAD or a heart transplant or something, and you can focus, you can focus those more complex cases at the main center and do the less demanding procedures, you know, elsewhere, and that obviously applies to general surgery and gynecology and whatnot. But you can see the financial benefit of a system like, for example, in the U.S., there's this HCA system that has hospitals over 17 or 18 states, and if you have several hubs of different expertise, and it would be financially beneficial for them not to move those patients around and operate. So there's some interesting little, you know, kind of vignettes where it would be beneficial to have the case. But I see where you're coming from, because it's such a foreign concept to what we are now.
You know, you say that you're going to localize the experts into one particular place, but you know, if shit hits the fan, you know, you will need experts to do the operation there. Right. So I think, you know, whatever it is, you have to invest in manpower there.
Yeah, and the question is, what kind of shit can hit the fan, and what is the therapy for that? And so if we're assuming that the remote site does not have the expertise to do, let's say we're doing a mammary takedown right now, and the plan is for Lalit to do a TCAP over there. This patient, for them to get a TCAP, they would have to go where Lalit is. Okay, they can't get a TCAP where they are, but they can get a cabbage, a sternotomy cabbage, or a mixed off-pump cabbage. They can get that because the expertise at the remote center has that. So say something terrible goes wrong, the arm fails, or the camera becomes non-usable, or the mammary gets divided, or something of that, you know, shit hitting fan. What is the solution? The solution is the patient will get what they otherwise would have gotten. So that's, I think, the level of care has to be at a certain standard where they would get that therapy anyway. And what this is an elevation above that. So now they're getting a more kind of demanding, or more, if you will, higher level procedure because of the tele. So I think you're absolutely right, and those safeguards need to be there, and they're there in the non-cardiac procedures, but for the cardiac procedures, they're even more demanding. So if you're talking about valve surgery, the way I philosophize it is, for example, if we were doing a case remotely and the patient had degenerative mitral valve disease, and you have an expert in the center that can do a nice repair, but the guys at the periphery, they're not facile in repair, it's a bileaflet valve, it's a Barlow, whatever, and they're gonna set it up, they know how to peripherally cannulate, they know how to put the clamp on, they know how to put the antegrade in, and then they open up the left atrium and they say, okay, come on down. And the center pipes in, and now the expert is sitting at the console. He does his magic with cords and rings and whatever, and he says, okay, I do the water test, no more leak, great. And then he goes to the next one, and the local team at their console closes up the left atrium and gets moving and decannulates. And so you kind of see where each type of procedure has a certain level of baseline expertise that's required on site. Yeah. It's teleproctoring and providing tele expertise for those parts. Like I could see a TCAB where the local person does everything, and once it comes to the anastomosis, he calls Dr. Yusuf, and Dr. Yusuf sews it, sews another one, and then goes on to the next case. Yeah, it's a very interesting concept, and you have to think about a lot about, because I think one of the things that the first inclination is to say, oh, this is a terrible idea. Why would anybody want to do this?
निकाल के कर दें सर?
Of course, medical legal is the big deal. I mean, that is the showstopper, exactly. And so you have to be very careful managing this from the medical legal standpoint. And the higher the acuity of the case, obviously, the more complicated that becomes. Because everything else is solved. The latency is solved. Do you go through fiber? Do you go through satellite? Do you go through 5G? Soon we'll have 6G. All that is fine. It's the medical legal and what type of expertise needs to be at the remote center.
So Da Vinci has, they've got two consoles, one for training and the other.
Yeah.
Right.
Yeah.
So if the local team has one console and the remote team has another console, so therefore actually two people are available to do the job.
Oh yeah, I mean I think that's necessary.
Yeah.
To have a console remotely where the patient is,
Yes.
and have a console at the central,
That would make it safer.
Yeah, potentially, because they could still continue the case
Yeah.
robotically if they
nothing-
had the
if
expertise.
some connection problem or some other
Right,
problem.
right, exactly.
The second thing I had a completely different note. We were harvesting a mammary, bilateral mammary, and when we had that shoulder problem, so obviously we kept the port a little bit forward, a little bit towards the midline.
Yeah.
So when we were trying to take the Lima, we got the right internal mammary, but when we came to the Lima, we found that we had created a hematoma on the side of the arm.
Ah. Even before you harvested it.
Yeah,
Oh.
because the arm was probably hitting, we had kept it too far.
Yeah. And was it not usable?
Very flat chest. Patient had a flat chest.
It was not usable, huh?
The problem we face in India
Bench,
Dr. Balki,
clean.
is small patients. So I
They're
had
doing
a
it.
problem once. So since then, what I do now is I always mark the anterior axillary line. And from there I mark the ports. Every patient I mark the anterior axillary line. And it's just about 1 or 2 finger breadths depending on patient size. We go anteriorly for the camera port and the shoulder port, the top port.
Did it.
So this way we have avoided that problem.
But I agree with you. I think if it's a short AP diameter or flat chest, it's hard. And maybe his solution, going from the right side so you don't injure the lita, is a good idea. Does that happen a lot, or just rarely once?
Yeah. Don't.
Yeah, it happened once to me as well. Placing the ports more laterally in a flat chest actually helps, and you can prevent injuring the left mammary, the shaft of the port hitting the left mammary. Placing the ports a little more laterally in a flat chest patients.
But the controversy, the problem is the left shoulder hits then.
Exactly.
So
You need that pushing maneuver. Somebody in the next to the bed, they'll have to push the shoulder for a couple of minutes probably.
So we have a very different solution for this problem. We use a pediatric port. Whenever we have a problem of the shoulder hitting, we use a longer robotic port, which is called the pediatric port. So what happens in the pediatric port, because your fulcrum changes. If you're taking a longer port, your fulcrum changes.
Yep.
And the swing is actually happening away from the shoulder. So this is something which we use, and although not recommended by Intuitive, because we are using 2 normal ports and 1 pediatric port, but we have found it to be very interesting.
I'm assuming that everybody does that. I guess not. Yeah, that's something that is a workaround that's not really great, because if you look at the inside of those intercostal spaces, you'll see that the excursion of the instruments is so wide because, like you said, the fulcrum changed. We call those the obesity ports because they're made for an obese patient. Yeah, I use that as a matter of routine, unfortunately, on the right arm. I don't like to use it, but my nurse gives it to me every time unless I say no because of the shoulder problem.
Yeah. For me, we most of the time we are using for this right port, and for TCAP we use the left side, and for endostabilizer we use bariatric port.
Bariatric.
Yeah.
Bariatric, yeah.
Bariatric.
Yeah.
And the another thing which we noticed with the shoulder was that we used to keep the arm a little hanging down.
Yeah.
Slightly. So that made the shoulder a little more prominent in thin individuals. And what we use doing right now is extend the arm behind.
So dropping the arm makes the shoulder more prominent.
Shoulder more prominent.
If you go too low,
bony part especially. So and then the first arm, third arm becomes a little difficult maneuvering there. And also that whenever we have it that the shoulder is being touched and we have some difficulty, we ask the bedside assistant to put the arm in between the shoulder and the third arm and then slightly push it down. That gives at least a few millimeters of movement, and we are able to get to the last end of the
Clean, please, clean.
The other thing you can do is you can burp the arm in.
Burp it lots.
Yeah, yeah.
As you go down, burp it a lot.
Warm saline से अच्छे से हो जाएगा.
Yes, sir.
Dr. Balki, how do you handle small hematomas when you see some superficial burn? Because everything gets blown out of proportion with the zoomed in image.
Ready.
How do you tackle this small hematoma on the mammaries?
Well, I mean, if it's very small and you can convince yourself it's just in the adventitia, then I don't do anything. But if it's bleeding, right now he's got 2 ports, 2 instruments, and a camera. If he starts to have major bleeding, the first thing that I would do is put pressure on it to try to, hold it back, and then take a look and assess the injury. If it's at the base of the branch, then you're kind of not feeling good about it, and that's when you start thinking about bringing in a bulldog and giving some heparin and putting a stitch in it. If there's a little small length of branch, then you can put a clip on it potentially. But it's a more difficult situation to deal with here than it is in the open setting. If you have bleeding that you can't control. But these things here, those are just venous bleeds there. I don't think these are hematomas in the wall.
This is all, this is all venous.
Venous, yeah.
Can you go to Cautery 30, please?
You had a question, sir?
Cautery 30, please. 30.
Is starting a robotic program, Lima harvest should be the first step, or because in what I felt was that in Lima your movements have to be very precise. So is it the correct first surgery to start when you're starting a robotic cardiac program?
Yeah, that's a good question. I think that we've had a conversation about that. Some said harvesting Lima first is best. I think it kind of depends on what you've been doing. Doing a pump case, doing a valve can sometimes be, a good place to start. Many surgeons use the robot just for that and don't even do coronaries. I personally started with a mammary takedown.
Sir, clean करते हैं 1 मिनट wait कीजिए.
I mean, just being pragmatic. I mean, 90% of what we do is coronary. So, that would be, I know it's risky, but that would be the easiest patient you would have to convince.
The way the Da Vinci people put it forward is like you do at least 20 limas before trying any structural heart disease. So 20 lima takedowns and then probably an ASD and then probably an MVR. That's what they advise.
Interesting. Yeah, I think it should be customizable. I don't think there's a one size fits all
branch
for any of this, depending on what you do and what your expertise is.
artery.
Can it change instrument? Clean
Cleaning weight.
and coat it down.
Dr. Balki,
Cautery
any idea of
25.
that airbay VIO which is moving out of DaVinci and then they're coming up with a regular cautery system and that will be in DaVinci 5. You're using a DV5. Right?
Oh yeah, DaVinci 5 is back to the regular cautery.
You can use the regular Covidian or
Yeah.
Okay.
So I use 2020 on the 5.
Clean.
The
Clean.
fourth
Wait.
generation is the only one
Cleaning.
they went to that other system, the Herbe. And that's very confusing because the numbers are strange, 1, 2, 3, 4, very weird.
And then watt, there's a 120, 180 watt change.
Yes. Yeah. So what do you put it at on that system for harvesting?
Put it at coagulation with 180 and cautery of 3. That's with the coagulation.
Watt 180 and cautery 3.
Yeah.
Wow, okay. Because I've heard other people say 2. But I have not used that for harvesting the XI.
Bifurcation आ गया ना.
Dr. Yusuf, probably you use the XI, no? You use the XI? What is your setting for the cautery? 3, huh? I don't use that system. I use the original SI. Yeah, so I use 20 cut, 20 collect. Yeah. I think that's a good idea, especially in the distal part.
Mic check. Just a kind reminder that we'll be concluding in the next 15 minutes.
Okay. You're under the gun, Lalit.
Oh, okay.
You have to leave in 15 minutes. I think you're getting down to the where you want to be, right?
Yeah. The vein, accompanying vein with this lemma is big, and I tried with the vein.
Did you harvest the vein the whole length or just in the bottom part?
Try to harvest the whole length, because I'm not sure, because this tele thing, and I don't want to injure lemma.
Yeah.
दिनेश ये हिट कर रहा है, ये लेफ्ट वाला हिट कर रहा है दिनेश.
हाँ, एक वो एक्सट्रीम में.
How often do you get a port site bleeding and how do you manage it?
Good question.
better
Somebody's asking about port site bleeding and how do we manage it. In the coronary cases, because we don't heparinize too much, it's very rare. And I generally don't worry about it in the coronary cases. In the valve cases, I worry about it, and we see it much more often. And we've developed this technique of using balloon tamponade on a regular basis. We've published on that recently, and it made a difference in our amount of bleeding and return to the OR for bleeding, where when we're done with the surgery and we're finished, we closed everything, put our tube in, take everything out. If there's any bleeding, cauterize from the inside and from the outside under vision. And then if it's still oozy and I'm not happy with it, if there's any drip whatsoever from any of the ports, I'll put a 14 or 16 French Foley catheter, blow up the balloon, tighten it up, and tamponade against the chest wall. And 95% of the time, once the protamine is in, I go back and check those, and there's no bleeding whatsoever. Whereas if you leave them alone and you just try to do cautery, it doesn't do the trick a lot of times, in my experience. So we're very happy with that approach, and my team always has a couple of Foley catheters for when we're finishing the case up. But in the coronary IMA takedowns, I haven't seen it too much.
40, 30?
30.
Put it in, blow up the balloon, and then pull back and put a clamp on the skin. And that generally tends to, as long as you've taken care of major arterial bleeding, it tends to eliminate it completely.
Clean karna?
Yeah, fast.
Clean fast. Cautery is 30.
Yeah.
Looks like it's pulsating nicely there, Lali.
Ready?
Yeah. This part with vein.
Yeah.
Yeah. Don't put.
We haven't seen you clean the camera once. What's up with that? Help me out.
Yeah.
Why is that? Is it immune to the spray?
Yes, because
the camera is good.
Yeah, I want to save time.
I clean the camera in my case at least 10 times.
Yeah, I saw.
You saw, okay.
Yeah, further branch.
Yeah, one of the things that I do that people have noticed when they come and watch is I keep the camera really close. My camera is right up against the target, and I think that's why I clean more often than not. But it's interesting. I mean, there's a little bit of smudge right here in the right lower quarter, but in general, it's been pretty clear.
नीचे जाता है तो सब ठीक है ना?
We had the difference like the temperature, the patient's temperature, the ambient temperature, and the camera's temperature. So we use that CO2 which is warmed it comes with the warmer, and that still we had to frequently change it. But recently what happened was in the OR we had a revamp of the AC system, and the ambient temperature changed a lot. And the number of times we take our port out has come down.
Interesting. So it was more fog than it was spray.
Probably.
LED का लीजन कहाँ proximal है?
Yeah, proximal?
हाँ, proximal है. रिपेयर चाहिए. ऊपर जाता तो ये तो बेस्ट है ना.
I think, sir, we have a proximal lesion, so I think is better. So this one, maybe.
You have a proximal lesion?
Yeah. So I think.
LED.
Oh.
Yeah.
Proximal LED lesion. Stop the dissection.
I see. Okay, so you have enough length.
Yeah, I think, or maybe we open.
Are you going to open the pericardium robotically, or just have Dinesh do it?
Maybe in my setup always open, then check. But here I think it's okay, or maybe I go and open this one. This where my right here. Dinesh.
Yeah.
I think Dinesh is taking your instruments. He wants to make a cut.
दिनेश.
हाँ सर बोलिए.
एडवांस करना है उसको राइट को.
हाँ कर रहा है. एक बार आप क्लच छोड़िए.
हाँ. Then pull out. What do you think, sir? I think this is okay, sir.
I think you're good. Yeah, you're good.
Yeah.
Awesome. Great. Round of applause.
Yeah.
So I think we're good to, you're going to proceed with an open case, and we'll hear about how it went maybe tomorrow's session. Do you want to wrap it up? Yeah.
So, ladies and gentlemen, respected faculty and delegates, that brings us to the close of day one of the cardiac track at SMRC 2026. Today, we witnessed something that deserves a moment of appreciation to Dr. Lalit Malik, who operated just a floor below, approximately 1,600 kilometers away from Delhi to Puttaparthi. Robotic cardiac telesurgery live in front of you. Now, just reflecting on what that takes, cardiac surgery, robotic cardiac surgery, and to do it across this distance in real time in front of the finest cardiac surgical minds in the world, with your own guru moderating the session, is a different level of courage altogether. Please, once again, to Dr. Lalit Malik, please give him a round of applause.
अपन ने ले लिया ये सूजी चला जाता है यार मंत्र तो
Our deepest thanks to our chairperson, Dr. Zambalki, whose guidance and moderation held this entire session together with the kind of authority that only comes from thousands of robotic cardiac surgeries and a lifetime of pushing this field forward. Thank you, sir.
And to all our thought leaders today, thank you so much for sharing your expertise so generously with us in this room. Thank you so much, ladies and gentlemen, for joining us today and participating actively in this session. A quick and important reminder, the faculty dinner is this evening. The bus leaves at 5 p.m. sharp from the main entrance of Bharat Mandapam. So please make your way there. And tomorrow morning, 8:30 a.m., right here in Summit Room, our faculty has saved their best for what's coming. We'll see you tomorrow at morning 8:30 a.m. sharp. Thank you so much once again, ladies and gentlemen, for joining us. Have a great evening ahead. Thank you.
We keep the chair in the way, but words yourself. Words yourself. Oh, my God. I go only. थोड़ा सा और एक कदम आगे आ जाइए. Alright, Dr. Before you begin, if you can just get your name and destination. I'm Dr. Alright, Dr. So, okay, after the way some say you were involved in procedure, not just tele surgery.
And Dr. Industry, maybe run us through a little bit what is this exactly and how does it help? I just leave everything from there to Bangalore to develop and we start the robotic at the awesome in the from 2000 where the processing and we have it there and this is near about 100 kilometers from there. I will find simple method. Basically, this is more about learning. यहाँ से पता चलता है तो बैरिकेड है तो लोग तो हम सही से get but I से भी मतलब ताकि भी जैसे और सब में कहीं सरकार बेसिक so and new change the problem kind of. Maybe let us know how this exactly helped you. Maybe I'm sure you've been doing robotic surgery, but anything that you maybe found out about your experience, just share it. We are the first one in collecting doing this type of surgery by surgery. We are the heart surgery. Is इसके लिए बड़ा मुश्किल होता है शहर में बस आके कराना अगर सर्जन तो मिल सकती है डाउट मेरे वहाँ पर ये सर्जन बैठा है What is the future looking like now? The accessibility of these machines? Thank you so much, Dr. for your time, and of course, congratulations on what I'm hoping is a successful one. Thank you, Dr.